what exactly is foveal cone phototropism?
So basically, it is the tilting of the foveal cones towards the ray of light. When you change the pupil location, you also have the tilting of the foveal cone towards the newly created pupil, and that they have documented, actually calculating the Stills-Crawford effect.
What do you think is the learning curve for pinhole pupiloplasties? How do they go about it?
So basically, the surgeon should be very well versed with handling of the iris tissue. So that's the first requirement. You should know pupiloplasty procedure to be done. For us and everybody, we commonly use the single pass phototropism procedure that we described about 5-6 years back.
Hi, I have Dr. Priya Narang with us today to talk about a very interesting topic which very few of us know the details about. Welcome, Dr. Priya, to our podcast.
My pleasure. Thank you for having me here.
You're welcome. So let's talk about what exactly is foveal cone phototropism. There's a lot of hype around this and not many of us know what exactly it means. Could you explain about that?
Actually, it's totally a newer concept, the foveal cone phototropism. Now, this concept has been into existence since early 1930s, but it has not been focused much on. And actually taking into consideration all the advantages that come up with that, I would just like to put in that foveal cone phototropism is like, you can just split the name. The phototropism means bending towards light. And when the photoreceptors and the foveal cones do that, we call this as a foveal cone phototropism. Now, how does that come into play? It is basically, the Stills-Crawford effect type 1 is like, when you have the rays of light entering inside the cornea into the eye, the central rays, they are focused the most and the peripheral rays are dimmed out. And that is what the Stills-Crawford effect 1 is there. And when you measure the Stills-Crawford effect, the peak point where it comes on is decided by the foveal cones. And that is what the directional sensitivity of the foveal cones, it actually decides the foveal cone phototropism concept. So basically, it is the tilting of the foveal cones towards the ray of light. So that is what we call it as foveal cone phototropism.
And how is this concept helping us as ophthalmologists? I mean, like in which aspect do you think we would be using it?
We actually relate this concept to the change in the shape and size of the pupil. Now, this can be post-traumatic or it can be created artificially with the surgery. So it's basically the correlation of the pupil size and location with the tilting of the foveal cone that we are taking into consideration. So basically coming to the fact is that, patients with corneal opacities, patients with corneal scars and all, we try, if you have a central corneal scar and you have a central pupil, the rays of the light, they do not actually happen to go inside the eye and create full illumination for the patient. So in these cases, what we try to just shift the position of the pupil from the corneal opacity to the side. Now, here comes in the factor of foveal cone phototropism. As it has been measured by many of the surgeons across the globe previously, what they have actually documented is that when you change the pupil location, you also have the tilting of the foveal cone towards the newly created pupil, and that they have documented by actually calculating the Stills-Crawford effect. So the Stills-Crawford effect comes maximum in the center of the pupil. So that's how they calculate that, okay, now this is just because the foveal cone photoreceptors are probably getting inclined towards the new passage or the new entry of light going inside the eye. So that's where it kicks in.
To make it more easy for people to understand, what you have told me is anyone with a corneal opacity or a corneal scar, where we usually would do a corneal transplant in these cases. And knowing the dearth for corneal tissues availability, then the chances of rejection, vascularization in these grafts, if we had another option to avoid this, then I think that would be great. So I think that's where this plays an important role. So for a surgeon who is starting out to plan on doing these eccentric pupiloplasties, are there some tips which would you
like? Absolutely. The first thing that the surgeon should analyze is the surface of the cornea, because the aberrations of the corneal surface increase as we go from center to the periphery. Secondly, when you create a pupil in the periphery, things become much more trickier, things become much more difficult at that point of time. So a wavefront guided image of the cornea should be available. And what we do it is, we do a Zernicke analysis of the surface of the cornea. And then what we do is we choose the site with the least aberrations correlating with the clinical image. Like you shouldn't have a clinical opacity on that part, but yes, you should be having less aberrations on the surface of the cornea. So that's the first thing. The second thing is trying to shift the pupil to the newly less aberrated location on the cornea so that you get good focus of light going inside the eye. Thirdly is the size of the pupil. We call this as a pinhole pupilloplasty. So it's not only just shifting a pupil. Now you cannot have a 3 millimeter or a 4 millimeter pupil located eccentrically, because then you have lots of aberrations going inside the eye. So we need to even close down the pupil to about 1.5 millimeters in size from all the sides, and also to locate it beneath the least aberrated cornea. So that's the concept. The rest of the thing, the photoreceptors behind, they usually take about 1 week to realign themselves. So you keep on monitoring the vision of your patient. The patient will markedly improve over the next 1 week post-op period.